It is my sincere pleasure to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform, Clirnet. It stands as one of the largest live digital semi platforms in India, providing a space for doctors to create and share medical content. Now, I would like to extend a special welcome to today's distinguished speaker, Dr. Amitav Banerjee. He holds degrees in MBBS, MD, postdoctoral epidemiology, medicine majoring in Community Government Medical College, Jabalpur, professor and head community medicine at Dr. D.Y. Patel Medical College, Pune. Once again, I welcome all of you at the today's lecture for the topic Mpox in Modern World, Critical Lesson and Proactive Strategies for Future Outbreak Preparedness. Now, I would like to give you a brief overview of today's topic. Mpox is an infectious disease that has seen a global rise in recent years. With outbreaks reported in several countries, the disease has two main types, clade 1 and clade 2, each with subclades. The DC has cautions about the possibility of recurring mpox outbreaks, particularly in MSM populations within religions or network where immunity from previous infection or vaccinations is low. So, without much delay, sir, I would like to hand over this session to you. Over to you, sir. You can proceed with the talk, sir.
Thank you, Swastika, and good evening to the viewers. It's always a pleasure to come on this Clirnet platform. And today's topic is Mpox. It was called monkeypox earlier. And what are the precautions countries should take? What are the proactive measures? So, as on today, from the lessons learned, there doesn't seem to be much of a cause for panic because we have been following the epidemiology, but there are certain enigmatic issues around the virus. So I will just give a brief overview. I will share the screen and then we will be proceeding with the overview of this. So this is the topic today, the critical lessons learned. And so I'll just see if so we start with the philosophy of Sun Tzu. He was an ancient Chinese warrior and a philosopher. He says, if you know enemy and yourself, you need not fear the results of 100 battles. If you know yourself but not the enemy, for every victory gained, you will also suffer a defeat. If you know neither the enemy nor yourself, you will succumb in every battle. So today's goal is to know the enemy, and we know or how we prepare ourselves also, know the enemy as well as know ourselves. So this will be the scope, the overview of the enemy, that is the monkeypox virus, the present enemy. What have been the recent attacks it has caused, and what is how the current outbreak is unfolding. Accordingly, we plan our strategy. We should not plan or overreach or cause undue panic. The media has already started saying they're deadly mpox, so that we should moderate with the actual data and the evidence. And epidemiology and natural history of the disease, how it progresses, natural reservoirs where the virus thrives, and whether we have those in our own country, those reservoirs, because then only we can predict how it will unfold in different countries. What are the prevention and control, and then we'll conclude based on this. So the historical overview is 1958. It was discovered in Asiatic monkey in Copenhagen, Denmark, and surprisingly, it was discovered in a research lab in Denmark, and the research was being done on poliovirus. And the monkey was imported from Singapore, macaque monkey. So there are a lot of enigma around it, because the natural reservoir is not monkeys. In a natural reservoir are small mammals, we will see. And this research was on polio. So we don't know. After 1958, the virus was almost forgotten and went in the background. And it was rediscovered during the last stages of the smallpox eradication. As you know, in the late 70s, mid 70s to late 70s, smallpox eradication was in its last phase, where house to house survey was being conducted all over the world by WHO to eradicate it, to find the last case of smallpox and eradicate it. And while they were searching in Africa, in Congo and Western Africa, they came across this type of pox lesions which resemble smallpox. And then when they did a investigation, they found that this was not smallpox. This was a much milder year, and it was labeled as monkeypox. It belonged to the same virus family, but it was much milder than smallpox. Smallpox had a fatality of 30%, and monkeypox has a fatality from 0 to 10%, depending on the host immunity, local conditions, the clades, the strains, we will see. Monkeypox infection, even then, this was forgotten again because this was limited. The monkeypox was endemic in Western Africa and Congo. Congo was supposed to have a more serious strain, which is known as clade 1, and Western Africa had clade 2. And the last year outbreak, or couple of years back, 2022-23, it was clade 2, which spilled out of Africa into USA and Europe, which was supposed to be a much milder. And this time the outbreak is in Congo, epicenter is in Congo due to clade 1, which it was believed is more aggressive. But how there have been few cases of clade 1 in the present outbreak in, say, Sweden, Thailand, one case in India, but it has not caused much of a secondary attack rates in these countries. They're just isolated cases, not related to each other, with a travel history to this endemic area. So it is behaving not very aggressively outside Congo. And there may be factors in Congo which we will see, which may be contributing to relatively higher mortality from clade. We'll see the mortality, we'll see the numbers. And 2003, it was the first time in 2003 monkeypox was detected outside Africa. This was in USA, and it was traced to prairie dogs. Prairie dogs are not big like dogs, they are small rodents. And they were imported from Africa. And other Gambian rats, rope squirrel, and from African of exotic species originating in Ghana. So they were, through the trade routes, small animals were imported, exotic animals. So they are the reservoirs of monkeypox, and some cases occurred in USA. Not much of a outbreak. Then the largest outbreak in history outside Africa was in 2022, biggest ever outbreak of monkeypox outside Africa. 1 lakh cases, almost 90,000 cases, up to 1 lakh cases from 122 countries occurred. And this was the details. It started in May 22. By end of this outbreak, there were almost 90,000 cases and 207 deaths from 192 countries, with a case fatality rate very low, 0.29%. And these also were due to co-infections with HIV, because HIV people were more vulnerable. So it cannot be solely attributed to the virus, but a co-infection with HIV and other STDs. India reported 30 cases with no deaths in the 2022-23 outbreak. So it was almost zero outside Africa, the lethality. So the media calling it a deadly is not very correct. Useful insights, because we have to know the enemy from its previous attacks. Useful insights as well as mysteries from this outbreak. Majority, almost 42% were aged 31 to 40 years, and 99.5% were males in this largest outbreak, almost a lakh people in Europe and USA from 122 countries. Only 10% needed hospitalization and only 0.04% needed ICU admission. So it was 90% were almost mild cases. Among affected, 43% were HIV positive. So, and 50% had other STDs. So this is the vulnerability. So we know whom it attacks. Only 0.33% were healthcare workers. So healthcare workers, the spread was not there. So it indicates that it does not spread very easily by casual contact. It spreads by body fluids, and it's behaving like a sexually transmitted disease outside Africa. So we have to follow the strategy of prevention of sexually transmitted disease. Then there were more detailed data from UK in the last outbreak. Of course, this was due to clade 2, and now the Congo epicenter is clade 1, which is supposed to be more aggressive, but as yet it has not shown any aggressivity outside Congo. So this is UK data on monkeypox from the previous outbreak. 97% cases were among homosexual or bisexual males. So you can imagine this is the risk group. 54% had history of other STDs, and 31.8% had 10 or more sexual partners in the last 3 months. You can imagine the promiscuity, the unsafe behavior, the irresponsibility which predisposes to getting this infection. So this requires behavioral change, sex education, use of condom. You have to educate this, and not only this type of behavior is spreading monkeypox, which is a self-limiting in most cases, but it is spreading HIV where there is no. It is a chronic infection, and then it is spreading other STDs. So you cannot attack the problem piecemeal. So you have to educate and behavioral change, communication, or safe sex in high-risk group. Synchronous, another mysterious was that when a communicability usually spreads, it spreads from person to person in the household, then in the community, then in the larger country, and then from other countries. So there is a chronology. Like even the coronavirus spread, the COVID from China to Thailand to Italy, then USA, then Europe, then. So here it is in the outbreak of monkeypox was simultaneously or synchronously erupted in the Europe and USA, most highly vaccinated countries for COVID, second, third dose. So this is a mystery whether it is a sort of a immune depression either due to COVID or due to the vaccine. We don't know. It requires research because the epidemiologically it is not following the pattern of a conventional contagious disease. It is erupting, and it is known that herpes zoster and all, when there is an immune deficiency, erupts. So this is also a virus which perhaps related. That's a question mark. We don't know. A communicable disease spreads, as I said, from person to person, and then so here it is simultaneously. So this is one mystery. The origin is a mystery. The behavior outside Africa is a mystery. So now let us see the present concern where we are to take proactive action. In July, August, large number of cases in Congo and surrounding, few spilling over to other parts of the globe. So as I said, this is Congo was the epicenter presently, is the epicenter caused by clade 1b. There are two clades. One is the Congo where the clade 1 is there, and other is the Western Africa where clade 2. In 2022-23, it was clade 2, which is supposed to be less virulent. I mean, it is supposed to be. Now here, this clade 1 is endemic in Congo, and both have got 1A, 1B, 2A, 2B. So this present 1A is little more virulent. So this present outbreak is due to clade 1B. Clade 1 is found in Congo and supposed to be which caused Laos outbreak in Africa in 2020. However, clade 1B is milder than clade 1A. So among clade 1 also, 1B is milder. As on today, 27,000 cases have been reported with 1,300 deaths, giving a case fatality of 4.8%. In the next slide, I have got a more recent figure where the case fatality is coming to 3.2% or 3.3%. We will see the next slide. Just I took it 1 hour ago from the CDC site because the Congo and other cases, the diagnostic facilities, the reportings are not very accurate. So they keep refining the data. So the present infection, that is the case fatality rate, not infection fatality rate, because we don't know the total infections in the community. Congo is a large country with a population of 99 million. So many people may be infected, they may be moving around, and that increases the denominator. In Congo, children comprise 70% of cases and 85% of death. This is also very important to know because children, the epidemiology in Congo and Africa is entirely different. Congo is a very poor country. There have been for decades, there is political instability, and the children and women, they hunt for small animals like which are the reservoirs. And 70% of cases are found in children in Congo because the transmission is zoonotic from animal to children. So they are exposed in the forest hunting for the small rodents, and they handle the carcass, and they may perhaps eat it also. So there, and since the 70% cases are in children, 85% deaths are also in children, and children, they are very malnourished. So these are another important thing, very malnourished. So they have got the one of the highest malnourished, undernutrition. So that also may be contributing, which may be giving the impression that clade 1, and clade 1 is more prevalent in Congo, that it is more lethal. Maybe the host factors, the poor nutrition, the poverty may be causing, and lack of health medical services. So they don't have access to medical services. So these all contribute to higher mortality, which will inflate the supposedly mortality rate. Because now children are affected in Congo, then the media started saying it will affect the children. We should think of children vaccination. This is not. We have to study how it is, why it is affecting. An odd case occurred in Pakistan, Sweden, Thailand, and Indonesia, and even India. One case has recently occurred within a month, I think, in Kerala. That was 1B. And there was another case still earlier, which is in Haryana. That was clade 2, which was circulating since last pandemic. So there have been one case, and all had travel history from endemic regions. No deaths outside Africa. You see, there is no deaths outside Africa. That's conveys something, that it is the. So this is the latest figure, as I said. This is just 1 hour back I had taken from the CDC site, that Congo has a total population of 99 million, and suspected cases clade 1 is 21,000. As I said, in the previous slide were 27,000, but this is the data as on 18 September. Death is 700, and this gives a case fatality rate of 3.33%. So, and the infection fatality we know, because we do not know, because the mild cases are not being, we are not having that denominator. So it may be still less. So this is the position, the spread outside Congo. Travel associated cases of clade 1B monkeypox has been reported from Kenya, Thailand, and India. Ongoing transmission is not believed to have occurred in those countries which had spread. Outside Africa, it has not caused fire. Just one isolated case, two isolated cases, not related to each other. So as it is not a very transmissible. It transmits by very intimate contact. No family members affected. So we have to question whether we have to just keep a watch. That's all, and educate the high risk group. People go to countries and indulge in sex tourism. That is a risky business. So we have to educate that way. That acts as a better vaccine. Clade 1 monkeypox was historically been associated with higher proportion compared to A. Now, however, recent data suggests, this is again from the CDC site, I took 1 hour back. Recent data suggests that previous severity estimates may have been high, estimates high, because they are not factored in the host resistance and poverty and other thing. For example, a study conducted in Congo showed that routine supportive care, and they lack to assess of care. If you give care, even in Congo, the clade 1A also is found to have less case fatality rate, lesser than even 0.2% than previously referred. Previous figures were 3 to 11%. That causes panic, 11, but that did not factor in the lack of health services, the lack of the poor nutrition. So the recent study in the CDC site said that even in clade 1A, the case fatality even in Congo is less than 2%. If you have access to health services, then clade V monkeypox cases appear to be clinically milder than clade 1A. And even clade 1A in Congo is milder than earlier thought, less than 2%. So you can imagine clade 1B will be still less. And then outside Africa means zero mortality. In addition, clade 1B cases in Congo have been associated with lower case fatality rate than clade 1A. No clade 1 monkeypox deaths have been reported from countries where monkeypox is not endemic at this time. There have been no 1A. 1A has only spread to Sweden, Thailand, and India, and some odd case in Pakistan or I think Indonesia. India reported one case of 1B Kerala and one case of 2B Haryana in the present outbreak. 30 cases in previous 2022-23 outbreak with no deaths. So do we panic? Congo, we have to see the context. Great political instability over decades, because know yourself is also important. So if you are have to fight the battle in Congo, we know the virus and we know the weaknesses or weaknesses if we are in Congo. Other countries, we have got health services, we have got better nutrition, we are strong. We have been dealing with sexually transmitted and HIV for ages, so we have got experience. So we don't have to worry. Congo is a politically unstable country. Over 6 lakh refugees in neighboring countries. So refugee camps are crowded, they can spread in neighboring countries. Unhygienic conditions, then sex trade goes on due to poverty. Poverty and malnutrition are rampant, and poverty leads to sex trade. Children hunt for small rodents in forests for food, more exposed. Fatality rates and risk groups in native Congo cannot be extrapolated outside Africa where risk factors and epidemiology is different. Prevention and control should focus on the determinants which vary across continents. So the same here does not apply, same site does not fit all. So this is the latest mapping. The endemicity is in the Congo and the Western Africa, and few odd cases outside, and India, one case in Kerala. So something about the enemy, again, virus belongs to the orthopox viruses, which is now eradicated, and also the same family, and cowpox and smallpox. Cowpox and monkeypox are very mild. So smallpox, though same family, monkeypox is very mild. And those generations which have been taken the smallpox vaccine after 78, 77, 1977, there were no vaccination was discontinued because smallpox were eradicated. So generations born after that do not have cross immunity. So that is one reason why the age is 31 to 40. Those who are 60, 70, 80, they may have had. So that is one reason. But anyway, even monkeypox itself in a healthy person is very mild. The question is vaccine warranted? We will see the groups where CDC and WHO have recommended vaccination, not for the general population. And again, as I said, name monkeypox itself is a misnomer, belongs to the same family, smallpox, more common in children, we have discussed, and illness is 2 to 4 weeks, and these are the rashes. Actually, rashes are generalized, and the outside Africa, it is behaving in a different way, we will just see. It is mild and self-reported case fatality 0 to 10% Africa, but now the revised CDC estimate is that in Africa also it is less than 2% of the severe strain also, clade 1. Among household contacts, the secondary attack rate is less than 10%. So there doesn't spread in the household also. Use of common towel, use of body fluid, use of common bedding may increase the risk from the lesions, but until unless there is intimate contact, the spread is not easy, and some hygiene can be advocated to household contact. Symptoms of fever, muscle pain, gland swollen, and rashes, which have to be differentiated from chicken pox and other cases of fever with rashes. Even herpes zoster can give. Human to human transmission is by intimate contact, while respiratory is not very efficient, and it doesn't spread very easily by respiratory route, because we have seen the healthcare workers, the attack rate was just 0.33%. So this is the reservoir is found more frequently among small animals like squirrels and prairie dogs. Prairie dogs are small dogs like rodents only. More frequently, antibodies are found in Gambian rats and elephant shrews. I think this is elephant shrew. The serological and viral studies in 1980s by WHO detected very occasionally antibodies in monkeys. So monkey is not a natural host, though it is called monkeypox. Most of the human cases were among poor children. 75% of poor children who lived close to animals and handled their carcasses. So these were I have already discussed this table, so we'll skip this. The changing epidemiology of monkeypox and future concerns, that is how to be proactive. Largest monkeypox outbreak in 2022 non-endemic countries. The spillover of the monkeypox in new permissive host cosmetic distribution could contribute to a virus becoming public health problem in humans. So the concern is that once it spreads from person to person, efficient. Now also it spreads to person. In Africa, it spreads from rodents to children, and but in maybe some sexually transmitted also, but outside Africa it is exclusively behaving like a sexually transmitted disease, and with intimate contact, sharing of needles, towels, and other things. So if it becomes more virulent, that is the concern. Usually if the natural mutation occurs, the virulence comes down. That is the natural history of viruses. Monkeypox in the Western world in 2003. As I said earlier, USA had some outbreak from importation of some animals from Africa. No human to human transmission traced to import of prairie dogs. In 2018-19, imported in Israel, Singapore, and UK, some nosocomial infection in the UK. So they have been sporadic outbreak, can adapt to wide variety of hosts and potential for adaptation and spread. So this is the only concern that if it, but over the 60, 70 years since its existence, it's not a new virus. Over 60, 70 years, it has not behaved. If it had to behave aggressively, it should have behaved. So now we don't know. Maybe that time we were getting smallpox vaccine. Maybe that may be one reason. Now effect has come down at the population level. Therefore, monkeypox cases are coming. So we should do more research and see the natural history. And it is in the high. So these are the different presentation. This is the left side is the presentation in Africa, the children. Whereas, as I said, outside it is behaving as a sexually transmitted disease by orogenital sex. So lesions may be in the oral, limited to the oral area, or it may be limited to the genital area. So asymmetry. So that is there. And massive super spreader events are due to these gay parties and pride parade and all, which happens in Europe from time to time, I think annually. Likely spread by two rape parties between May 22. Prolonged intimate contact, concomitant HIV and STDs. Most below 40 years, so no protection. Silent human tumor is less likely. But after settlement in non-areas, mutations, that one fear of mutation, which is as on today is a theoretical risk, and even in theory, usually mutates become milder. So we have to just watch. As now, it is not showing any signs. So it is a sexually transmitted disease. Rash on thighs, as I said, rash on the picture. Other parts, sometimes no, only painful. Sometimes have flu-like symptoms. So there may be varied presentations. It lasts 2 to 4 weeks. Testing kits, as I said, India not proactive. We may have overreacted a little. Already RT-PCR kit has been designed for tested for, yeah. The kit has been approved by, and the maker of the kit capacity to manufacture 1 million. I don't think it will be required. You have to see the resources, the expenses, the cost benefit. The test can be validated by ICMR, and it is said to have 100% scientific specificity. This also appears slightly, I mean, unrealistic. No test has that. So we have to see, we should not resort to mass testing unnecessarily and cause panic. So these are commercial interest will come, but as on today, we have to wait and watch. We have few test kits. I don't say we don't have, but only those cases selectively we can at the most do it in high risk groups, and clinical surveillance can be done, case surveillance with symptoms of rashes and lesions in the high risk group. That should be there. Mass testing in the general population, the way they have thinking of rolling out is not very logical as on today. Vaccine again against monkeypox, multiple vaccines, all are derivatives of smallpox vaccine. In the United States, they are modified vaccine Ankara vaccine. They are, and there are two vaccines are presently available, again derived from smallpox, but it has got, see, earlier smallpox vaccine had very large number of side effects. It's not a very safe vaccine, but that time we had, because the smallpox disease itself has a 30% mortality rate, even 1 to 5% side effects severe we have to, it's definitely cost benefit. But here in monkeypox, the fatality itself is 0.2% or less than 2%. We have to really weigh and only perhaps give to high risk groups. Serum Institute has also announced that it will provide vaccine, but it won't be required at a large scale because it's not spreads fast in the large general population. Even in Africa, they are planning to send vaccines to Africa. So it is okay, it's a stopgap measure, but the long-term measure has to be to improve the socioeconomic conditions so these children nutrition improves. They don't hunt for small animals from where they get the infection. All those will actually have a longer self-sustaining impact than temporary stopgap measures like vaccines, which is under emergency use authorization, I suppose, because it has never been tested against monkeypox. So this is again a very fast track development. These are the WHO recommendations of vaccination. Health workers at risk of exposure, those who are working with the virus, men who have sex with men. Best is to have safe sex anyway. Vaccine is there. People with multiple sex partners, sex workers. So these are the recommendation, and these are the CDC recommendation I just took just now. Recommend vaccination with the 2 doses Genos vaccine to regardless of gender identity or sexual orientation. If they are traveling to a country where clade 1 monkeypox is spreading between people and they anticipate experiencing any of the following: sex with a new partner, sex at a commercial sex venue like a sex club or bathhouse, sex in exchange for money, goods, drugs, or trade, sex in association with large public event, rape party or festival. So those who lead very adventurous life, those who are in the fast lane, who live in the fast lane, so CDC recommends them. As I say, it is okay. Again, it is a stopgap measure, but in the long run, better to change, bring about behavioral change, communication, because it is piecemeal solution. You have vaccine for monkeypox, but you don't have vaccine for HIV. So your person will be vulnerable to HIV. He takes vaccine, he thinks he is protected against everything. Then he is vulnerable to STD. So that way, you have to take a call that way. Recommend starting if possible the Mpox vaccine series at least 6 weeks before travel begins. 2 doses should be given 28 days apart, and it takes 14 more days for immunity to peak. You wait for 14 days before you hit the rape party. So that I don't know if people who indulge in such impulsive behavior, whether they have the patience to wait for 14 days. So that's another behavioral aspect. Take home messages from this is that monkeypox surveillance should be only high risk groups, no point of population panic. A self limiting disease with almost zero mortality outside Africa, where there is access to health care. It should not be cause of panic, stigma, or even overreaction, closing of borders and other things. A good public health infrastructure, this is the most important. A good public health infrastructure will serve like a strong army to ward off future threats from emerging and re-emerging diseases. Not only Mpox, Mpox is a very mild thing, it has got hardly any impact. Without causing panic among policymakers and people, leading to knee-jerk reactions and collateral harm. Closing borders, closing trade, closing schools, it causes more harm than good. So these are some of the references I have taken from the source, WHO, CDC, and this is the last reference I said, number 9, which I have got the latest figures updated till 18th, and I end here, I think. So I will stop sharing the screen.
Thank you
Thank
so
you.
much, sir, for your comprehensive talk. So, sir, we have received a few questions from our delegates. Can I have your permission to share them to you?
Please do, please do.
Okay, sir. Sir, this is the first question.
Yeah, this is a global disparity equity, and the African continent is that's why most affected, as we have also brought out in the discussion that there is poverty, there is undernutrition, there is political instability, and the children have to hunt for small rodents. And naturally, and then the refugee problem, over 9 lakhs or 6 lakhs, 6 to 9 lakhs refugees from Congo and neighboring states. So they, when the refugees go, they spread the infection. So it is spilling over into the other African countries and in the low and middle income African countries, and that's why there is a planning of sending vaccines there, but that will be a short-term measure because vaccines are not tested for against monkeypox. And secondly, we don't know how long immunity will last. And the vaccination, mass vaccination also has logistics problem, particularly in low and middle income countries. So basically, it is a question of inequity and disparities in healthcare and lack of access to healthcare. So I agree with this. It is not only monkeypox, all diseases are aggravated because of this.
Sir, this is the next question.
Yeah, this is very important, and this, of course, in Africa, the epidemiology is a little different because it is from animals to humans. So, socio-behavioral research, that social research, ki why do they hunt? Because we know it is due to poverty. It's a social issue, and behavior out of necessity. So, that is one aspect. So, once we have to address that, we cannot give health education on this without providing for food and other things. So, we have to match the action, like donor countries are thinking of sending vaccines, they can better think of improving the nutrition and living condition. That is one aspect. Second aspect is outside Africa, it is behaving like a sexually transmitted disease. We have seen the data from the last pandemic that over 1 lakh cases were analyzed, and 90% were in males, and majority were men having sex with men. They are having multiple partners, more than 10 partners in the last 3 months. So these are the socio-behavioral aspects which requires addressing. So definitely this messaging would have a long-term impact on checking the spread of monkeypox outside Africa, where it is behaving like a sexually transmitted diseases. Definitely, this is a good question.
This is the next question, sir.
Models are very difficult. I say mathematical models have been misguiding us in the last pandemic also, and it will misguide us more in a sexually transmitted disease, because models are mathematical. When mathematicians work in models, they treat humans as inert units, all are same units. Whereas as in the previous question we brought out, it is a socio-behavioral aspects. Then high risk groups are not homogeneously distributed in the population. There are pockets of high sexual active individuals, commercial sex workers, multiple sex partners, men having with sex, drug addicts. It is not homogeneously distributed in the general population. So it would, the modeling, it will not, you require more social scientists and more social research than models in this monkeypox or any sexually transmitted disease, which cannot be extrapolated by models across the year. And as on today, whatever we have seen, even if you want to make models, the data from the Congo cannot be extrapolated to the world because the Congo conditions are different. The reservoir is there. In outside the Congo, those small rodents, squirrels which contain, they are not present. So it has to be transmitted by sexually transmitted. So models, there are a lot of variables which are different across the world, which will make models highly inaccurate. So modeling, that's all.
Thank you so much, sir. Thank you for
Thank you.
addressing all the inquiries from the participating doctors. We would be glad to conduct a session with you in our near future again. I extend my gratitude to all the participating doctors for your consistent support to our platform. Lastly, before ending the live, I would like to request you all to follow us on our Facebook, Twitter, LinkedIn, and Instagram pages to stay updated on the latest medical information. So, with all your permission, we can end this session here.
Okay, thank you, Swastika.
Thank you so much, sir. Have a good day, sir.
Thank you.